Yeah, good guy. I just want to welcome everyone, and we might have more join us. We have a lot of folks, and so that have registered to come for today. So we're really excited to have everyone joining from a lot of different countries and spending part of your Saturday with us. I'm Alice Lara, and I am the CEO of the SADS Foundation in the US. And so we are sort of behind the scenes with this, but I just wanted to welcome everybody. We're partnering today with SADS UK, with SADS Germany, Deutschland, and with the Arrhythmogenic Cardiomyopathy Association of Germany, and also with SAMS from Spain. And so we're going to have some breakout groups later that will be in Spanish and also in German, and also a SADS UK breakout later on in the program. I would also like to thank our sponsors, without whom this meeting would not be possible today. The two sponsors for this series of meetings are Medtronic and Tenaya Therapeutics. And finally, I want to thank all the medical experts that are joining us from the UK, from Italy, from Germany, and from Spain to really give us their best knowledge of where we are now in this exciting world, as well as answer all of your questions or about your SADS condition. So I want to turn it over to Anne Jolly, who is the founder and the CEO of SADS UK.
Thank you, Alice. And just really want to reiterate again, thank everybody for joining the SADS virtual conference, and for SAMS in Spain and SADS Deutschland for participating and helping with the conference. I'd like to thank everybody for joining, and all our consultants and speakers today for giving up their time. And we're looking forward to a really full day, and it should be quite an interesting day today. So I'm going to start off, I'm going to share my screen. So you should see all the speakers today. So we have Dr. Greg Meller, who's going to speak about medications and devices, and Dr. Lima Robert will speak about genetic testing and defining risk for patients with inherited cardiac conditions. We have Dr. Silvia Priori, who will be giving a sneak peek into tomorrow. And we're going to listen to Ben, who will give a patient perspective of living with an ICD. And I'm pleased that consultant in clinical genetics, Professor Devendra Kumar, will join our speakers later for the question and answer session, which will start at 11:45 and should finish at 12:30. So if anybody has any questions, we'd be pleased for them to save them for their question and answer session. So at 12:30, we're then breaking out into the groups. So we have questions and answers with breakouts in Spanish, German, and English. Esther Cosafreda from SAMS in Spain will be introducing Dr. Georgia Brugada and patient. Catherine Luttiging from SADS Deutschland will be introducing Professor Silke Kauferstein and patient. We have Ruth Biller from SADS Deutschland, who will be introducing Professor Matthias Paul and Dr. Britt Maria Beckman, again with patient participation. And SADS UK will introduce clinical nurse specialist Amy Hardy-Wallace, and again there'll be patient stories, and all of these breakouts will be followed by questions and answers. And Esther, Catherine, Ruth and myself will explain a bit more when we introduce the agenda for the breakouts at 12:30. So as I said, we're really pleased to be holding the virtual conference with SADS International and SADS, or the other SADS organisations. SADS UK now know how helpful it is for patients. We held the first international SADS conference in London in 2002, and that was for medical professionals and patients, and a lot was shared during that two-day conference. Researcher Dr. Catherine Timothy was able to characterise the Timothy syndrome after meeting families affected affected at the conference. The inherited aspect of the SADS conditions was shared, and many people returned to their GPs for specialist referral for heart checks after they might have experienced a SADS death in the family. One gentleman came along to the conference. He'd been sent one of our leaflets about the long QT syndrome. After being at the conference and hearing more about the condition, he went back to his GP, and it was later discovered that he was living with the long QT syndrome. So they were just a couple of the discoveries that were made from that first conference, and we've held conferences every year ever since. So SADS UK have got a long history with the SADS Foundation and Canadian SADS, going back together over more than 2 decades. And more recently, SADS International was formed, and SADS UK were pleased to be part of the organising group to do this, so that all the SADS organisations are working in unison. So promoting and installing defibrillators is an important part of the work that we do from a practical standpoint. We also provide CPR and defibrillator training, and we encourage strategies to be put in place in readiness should a cardiac arrest happen. I'm just going to share my screen again here. So from an educational and preventative point of view, the SADS organisations promote the warning signs, and these are to encourage people who might be at risk to seek medical advice. And you'll see there fainting, syncope or seizure during exercise, excitement or startle, consistent or unusual pain or shortness of breath during exercise, or a family history of unexplained sudden death in a young person under the age of 40. And this includes drowning suddenly, or maybe a car accident, which is in mysterious circumstances. So as I mentioned, the charity funds into research, and this is Catherine Timothy. And I spoke about Catherine, excuse me, earlier on, being able to identify the Timothy syndrome. Catherine works in the fields of cardiology and human molecular genetics. Her scientific and medical research has resulted in further understanding, especially regarding the long QT and Timothy syndrome. And Timothy syndrome was actually named in her honour after she described characteristics associated with this syndrome. She's one of the original pioneers of long QT genetics, developing the first remarkably large QT family pedigree for genetic linkage studies back in 1989. More recent research includes research into the short QT syndrome, and Graham Stewart, the lead cardiologist of the Inherited Cardiac Condition Service in Bristol, along with Jules Hancox, the Professor of Electrophysiology, worked together to understand how particular gene mutations lead to altered potassium channel activity in the heart in the short QT syndrome. Through laboratory studies of cells engineered to express these mutant ion channels, their research team has characterised the changes in function that lead to excessive potassium ion movement in these forms of the short QT syndrome. And this is more research that we're funding, and working with Cecilia Gonzalez and Christine Stratman, SADS UK funds an international paediatric Brugada registry since its launch in 2021. The registry currently includes over 30 collaborating sites from 14 different countries spread over 5 continents. It's expected to enrol around 300 individuals, which is big data for a rare disease like the Brugada syndrome. And it's created to follow affected individuals and their clinical course over a period of 5 years. The registry can give invaluable information about early markers of risk and clinical disease. Now, it's great news that more defibrillators are being installed in schools and in the community. And we spoke earlier with Mark about how this is how we're getting more survivors. However, there doesn't seem to be the support in place for these people. So support is needed for people who've survived and for family members who might have witnessed it. And the charity supports these people as well as rescuers. So both of these events can leave people feeling quite traumatised. And SADS UK are working with the all-party parliamentary group for defibrillators to ensure quick access to defibrillators and also support for people who might have been impacted by sudden cardiac arrest. So as I mentioned, we've installed thousands of defibrillators in schools and in the community. And with each defibrillator put in place, we organise CPR and defibrillator training. And the good news is that more lives are being saved. And every year we hold the Lifesaver Awards. And with that, we're honouring lots of people in the community from all different walks of life who are saving lives. So that's been really heartwarming to know that these lives are being saved. So that's just a short overview of some of the work of SADS UK. I'd like to now pass over to Dr. Greg Meller, who's going to speak about medications and devices. Are you there, Greg?
Hi, Anne. Yes, I am. Thank you very much. I'll just share my screen. Hopefully you can see that now. Firstly, to say thank you very much for the invitation to speak to this morning. It really is a privilege to speak at this sort of meeting. Anne asked me to talk about personalised medicine in SADS conditions, and particularly about drugs, denervation and devices. In terms of my background, I'm a consultant cardiologist. This is where I work, Royal Papworth Hospital in Cambridge in the UK. I trained in Cambridge and have also worked in London and Vancouver over my clinical training. I've been a consultant here for about 6 years now, and I run our inherited arrhythmia service. So we're going to talk about personalised medicine today. I think this is a bit of a buzzword in medical circles recently. This is a formal definition from the National Human Genome Research Institute in the US. And what we're talking about here is using a patient's individual data, if you like, particularly around their genetic profile, to focus medical treatment on that individual rather than treating everybody in a similar way. And I think SADS conditions are a very good example of how personalised medicine is already making a difference in our clinics. The clinic that we run, we have a very simple mission statement. Our ideal is to prevent sudden cardiac death in these conditions. However, one could argue that this would be relatively easy to do by aggressively treating all people. So lots of medications, lots of procedures, and lots of defibrillators will help sudden cardiac death, will help prevent sudden cardiac death. But that will have a negative impact on our patients' quality of life. So our mission statement is to prevent sudden cardiac death with a minimal negative impact on our patients' quality of life. We know that many of these SADS conditions don't carry any day-to-day symptoms, and the impact on quality of life is all through the treatments that are required. And so if we can tailor those treatments more specifically, we can avoid unnecessary negative impacts on people's quality of life while still preventing the horror of sudden cardiac death. Another tool that's integral to how we run our clinic, and I think where personalised medicine really helps, is shared decision making. And this comprises 3 parts, particularly when we're talking about assessing risk. First is risk calculation. I'm not going to focus on risk calculation today, but this is an area where personalised medicine is really making a difference. There are now a number of disease and genetic specific risk calculators for conditions such as long QT syndrome, arrhythmogenic cardiomyopathy, and lamin-associated cardiomyopathy, where a patient's genotype and clinical features allow us to predict their risk of sudden cardiac arrest over the next few years and therefore guide treatments. Of course, once you make that risk calculation, you have to then balance that against the risk perception of an individual. We all feel differently about risks, and we all have different tolerances to risks. And when making these decisions, it's very important to realize that not all people feel the same about a certain level of risk. And the bridge between these two, is the risk communication. This is an area where I think there's a lot of work to do. Translating these complicated models and percentage risk of sudden death into something meaningful for people, I think, is a real challenge, and hopefully we'll have some better tools in the future. So we're going to focus today on the SADS conditions, and particularly what we refer to as the inherited arrhythmia syndromes. So these are a group of electrical heart conditions which all can pose a risk of sudden cardiac arrest. And in general, we think of these as being single gene disorders. So they're caused by a variation, often causing loss of function in a particular gene, and therefore can be passed on through families. Of course, the genetics are more complex than this, but it's a nice way of segregating them together. The most common and most well-established of the inherited arrhythmia syndromes is long QT syndrome. This is the area where personalized medicine has really made the biggest impact so far, and we'll focus on this condition primarily. Brugada syndrome is another inherited arrhythmia syndrome, which is a frequent cause of sudden cardiac arrest, often in young, otherwise healthy males. Catecholaminergic polymorphic VT, or CPVT, is an ion channel disorder primarily affecting children and young adults. And then there are a number of other either very rare or less well-established inherited arrhythmia syndromes, including short QT syndrome, early repulse syndrome, calcium release deficiency syndrome, and unexplained or idiopathic VF. So personalized medicine is already, as I said, already making a difference for these three main conditions. So when we think about long QT syndrome, there are a number of potential treatments, and these will all be influenced by the patient's genetic subtype and their individual risk. So we'll talk about exercise advice, drugs known to prolong the QT interval which should be avoided, beta blockers which are commonly recommended in long QT syndrome, and then adjunctive therapies such as sympathectomy and defibrillators. In Brugada syndrome, again, we know there are drugs which can aggravate the condition. We know that fever can be a precipitant for arrhythmias, particularly in those with sodium channel genetic variants. Defibrillators, quinidine, and catheter ablation all have a role in treatment of Brugada syndrome. And in CPVT, again, we focus on exercise advice because of the very strong link between exertion and arrhythmic events in CPVT. We'll discuss about beta blockers and flecainide as medical treatments for CPVT, which also can be treated with sympathectomy and defibrillators. And we'll focus a little bit on defibrillators at the end of the talk across all conditions. In addition to specific medical treatments, personalized medicine also enables family screening, either through clinical or genetic testing, and this has a very important role. But perhaps what is less well appreciated is the impact on mental health that a personalized medicine approach or a specific diagnosis can allow. Often, if you're thinking about a cardiac arrest survivor, if there's no known cause, this can cause a lot of psychological difficulty in coming to terms with the events, and having a specific diagnosis and mechanism can help understanding and moving forward. Clearly, the more we know about the precise cause of a cardiac arrest, the more we can discuss about what the future may hold, and as mentioned above, various lifestyle and medical treatments specific to that diagnosis. So lots of reasons to try and be as specific as possible in making a diagnosis for our patients. So we're going to now just move on to long QT syndrome. As I said, this is the area where personalized medicine really is well established, and particularly with thinking about how we assess risk in long QT syndrome. This is data from an Italian registry run by Professor Priori, who we'll hear from later on this morning. And this shows the interplay between the QT measurement on an ECG, and the patient's genetic subtype in informing their risk. So in this table, you can see as we go from the top to the bottom with the QT measurements getting longer and longer, the risk of an arrhythmic event becomes higher. But also as you move from long QT type 1 to 2 to 3, which each have a separate genetic cause, the risk gets higher. Therefore, the risk is lowest in long QT1 patients with a relatively normal QT interval. Conversely, much more highest in long QT3 patients with a very long QT interval. And there are now risk modeling calculators that will give a very specific prognosis for individual patients based on these parameters. And again, that comes from Professor Priori's lab. Maybe we'll hear some more of that in her talk. We also know that the particular genetic subtype of long QT is associated with risks in different clinical scenarios. Perhaps the most well-established and most well-known is that patients with long QT1 are more likely to experience arrhythmic events during exercise. This is the data from the original paper back in 2001 that showed this. So of the long QT1 patients, more than half of those had their arrhythmic events, had their cardiac arrest precipitated by exercise, whereas long QT2 was most commonly with sudden emotional arousal, and long QT3 events much more common during sleep than in exercise. And we think that swimming is the highest risk activity in long QT, and there are various physiological reasons for that. The QT gets longer as heart rates go up during exercise. The changes in temperature and intermittent breathing necessitated by swimming changes what we call the autonomic balance, so the levels of adrenaline in the heart, and this leads to abnormal extra beats, which then can trigger the cardiac arrest. However, historical recommendations to avoid all sports in long QT syndrome and indeed in other SADS conditions is not really backed up by modern evidence. The Mayo Clinic, led by Mike Ackerman in the US, has done a lot of work looking at the safety of patients with long QT syndrome returning to sports. And I won't go through the numbers on this slide in detail, but it's really just to highlight that patients with long QT syndrome, if they are appropriately counseled and appropriately treated, can often return to a variety of sports, including competitive sports, without any risk of sudden death. And the editorial that came along with this article was entitled "Moving Towards a Long and Happy Life with Genetic Heart Disease." And again, I think this is very important. It's not enough just to prevent patients from becoming unwell, but we have to facilitate people to live a long and full life as well. So we talk about lifestyle advice, we talk about avoiding medications. Many of you may be aware of the Credible Meds website and associated app. This is for long QT syndrome and is very reliable and continually updated. We encourage all of our patients to download the Credible Meds app and show it to their general practitioner and their pharmacist if they're ever prescribed any medication. We talk about avoiding dehydration and salt loss, particularly during times of illness, such as diarrhea and vomiting. And we have an approach where we talk about safe sports rather than avoiding sports. There will be some individuals where continuing sporting activity is not safe and is not appropriate, but these are the minority, and our philosophy is to try and allow people to continue to be active as much as possible. In terms of medication, we know that beta blockers are very, very effective in long QT syndrome. They reduce the risk of further events by more than half, and maybe even by more than that. It does seem that the type of beta blocker that is prescribed is important, and what's referred to as the non-selective beta blockers, so propranolol and nadolol, are superior to other drugs such as metoprolol and atenolol that have been used historically. The graph on the right-hand side of the slide shows some data from a clinic in New York, showing that in the green line, the patients on propranolol and nadolol were much less likely to have a further event compared to those on metoprolol. Beta blockers work best for people with long QT syndrome, type 1, and probably specifically depending on where the genetic variant is within that gene. But they are also protective in long QT and to a certain degree in long QT3. Long QT3 is caused by an overactivation of the sodium channel, and therefore blocking this channel specifically with drugs like mexiletine can be very protective and also shorten the QT interval. Beta blockers are satisfactory for the vast majority of people with beta blockers. This data again comes from the Mayo Clinic, showing that 60% of people are treated with beta blockers alone. But there are a number of adjunctive therapies for some people who need them. Left cervical sympathectomy is an operation often done with a minimally invasive approach where the nerves that supply adrenaline to the heart are cut at the base of the neck, therefore effectively providing a surgical beta blocker to the heart. It's recommended for people who continue to have episodes of blackouts or syncope despite taking medication, or those people who are unable to take beta blockers but have a significant risk of future events. And finally, in those people with very aggressive forms of long QT syndrome who may have a defibrillator and continue to receive shocks from their defibrillator. The surgery is difficult, and it's important to find a surgeon who is experienced because side effects are relatively common from this operation. And these reflect changes to the supply of adrenaline to other areas of the body. You can get changes in sweating levels between the right and left hand, color changes, and these can affect skin flushing in the face. However, although these things are common, surveys of patients who've undergone sympathectomy consistently say that they would go through the procedure again because of the benefit it has offered them in terms of protection from their arrhythmias. At the other end of the scale, it's increasingly realized that there are a group of long QT patients where their long-term risk is low and may not require any specific medical therapy beyond the lifestyle advice we've already mentioned. So again, from the Mayo Clinic, nearly 10% of their current cohort meet this criteria. They tend to be patients who have never had any symptoms, who were older at the time of their diagnosis, and who have a relatively normal QT interval. So many of these patients would have been identified through family screening protocols. And after appropriate counselling, these patients decided not to take any medical therapy, and none of these patients had any clinical events over the following 7.5 years of follow-up. And it's said that they had an improved quality of life compared to those patients on beta blockers. So certainly, again, risk assessment is very important, and a shared decision-making approach, both to identify these people at very high risk, but also those people at low risk who may not need unnecessary treatment. Moving on to Brugada syndrome. So this is an electrical heart condition generally caused by a change in the gene called SCN5A, which is one of the important ion channels in the heart for generating electrical signals and conducting them from cell to cell. It's diagnosed by this very specific pattern on the ECG called a type 1 Brugada ECG pattern, and is associated with a risk of sudden cardiac arrest, typically during sleep and typically in men in their 30s or 40s, although of course can affect people outside of this description. Differently to long QT syndrome, our risk assessment in Brugada syndrome is still imperfect. We don't have specific risk calculators, and much effort has been made to identify detailed risk profiling for Brugada syndrome, but if we're honest, we've not cracked it yet. What we do know is that people who present with symptoms, either cardiac arrest or blackouts, are at a higher risk of having an event in the future. And those people whose ECG is spontaneously and continually abnormal without other factors such as drug testing or fever also have a higher risk. So on the left-hand side, you can see a 2x2 table showing that those with symptoms and an abnormal ECG in the red square are the high risk. those who have never had symptoms and only had a provoked abnormal ECG are at a low risk, and then the groups in between at moderate risk. On the right-hand side is our flow chart from our clinic and how we manage our patients. So those at low risk, which are the vast majority of patients with Brugada syndrome, thankfully, do not need any specific medical therapy. They should avoid medications, aggressively treat fever, and avoid alcohol binges, as these have been shown to precipitate attacks. Those patients at moderate risk, we do begin to discuss the role of a primary prevention defibrillator, but also more recently have been using a medication called quinidine. This is actually a very old-fashioned antiarrhythmic drug that has recently had data supporting its use in Brugada syndrome and other forms of SADS conditions. And those patients are at high risk, we do recommend a defibrillator, and then possible secondary treatments, including quinidine or catheter ablation. So this photograph is from one of our patients. He very kindly agreed for us to show it. It shows his defibrillator up there in the front of his left-hand side of his chest, and also his Brugada ECG tattooed on the right-hand side of his chest. The image on the right-hand side shows what we call a 3D map from a catheter ablation procedure. And this is to highlight that this procedure is becoming the evidence for this procedure is becoming increasingly solid. We recommend this in patients who have clearly high-risk disease, who have had a defibrillator and continue to have shocks. And we know that by ablating, so cauterizing the outside surface of the right ventricle, we can reduce that risk of further events significantly. It is a big procedure and there are procedural risks to it, which is why it's not recommended for lower risk patients. Now, finally moving on to catecholaminergic polymorphic ventricular tachycardia, or CPVT. This is an electrical condition of the heart characterized by cardiac arrest precipitated by exercise or extreme emotion. And this is because the heart responds abnormally to surges of adrenaline. The problem is with this molecule on the bottom right of the screen here called the ryanodine receptor. And CPVT tends to present at a young age, and particularly in young boys collapsing on exercise. It doesn't have any resting ECG abnormalities, and the diagnosis can only be made really by exercise testing. So we are continually reminding our pediatric colleagues of the importance of exercise testing in young people who have loss of consciousness, particularly if this has been associated with exercise. Medical treatments for CPVT are generally effective, but maybe less so than in conditions like long QT syndrome. Similarly to long QT syndrome, nadolol and propranolol are the preferred beta blockers. Maybe not recent now, but data from Christian van der Werf and colleagues in Amsterdam demonstrated that the addition of flecainide to beta blockers can further reduce the risk of events in patients already having events on beta blockers. And there's now also data that for those people who cannot take beta blockers, flecainide alone does offer some protection. In people where medications are not tolerated or not giving enough protection, then sympathectomy, similar to long QT syndrome, can be helpful, although it's probably, again, not quite as effective as it is in long QT syndrome. And of course, there's always the role of defibrillators. There's a lot of concern about defibrillators in CPVT. And while they certainly do have a role, we need to be very careful about how these devices are implanted and programmed. The particular arrhythmias that people with CPVT experience often are not shockable, so the ICDs cannot terminate them. And if an ICD gives a shock inadvertently, that can cause an adrenaline surge that then goes on actually to cause a cardiac arrest. So very careful consideration about ICDs in CPVT. So one last few comments about defibrillators. I know we're going to hear more about what life is like with a defibrillator. Clearly, defibrillators can save lives. This is data again showing how many patients experience a life-saving shock for a variety of SADS conditions. Secondary prevention, this is a group of people who've already had a cardiac arrest, versus primary prevention, those who've not had a cardiac arrest before but are deemed to be at risk. So the rates are higher in those who've already had a cardiac arrest than those who have not had one before. And so we do know that defibrillators, when used appropriately, save lives. However, there are significant problems with defibrillators, particularly the risk of what's called an inappropriate shock. So a shock from the defibrillator when someone's not in cardiac arrest, often completely conscious and exercising. This can be very painful and very psychologically harmful. And there are a number of other complications associated with having a device inside you for many, many years. And these can include battery depletion, lead fracture, and infection. And so ICDs can, sadly, reduce the quality of life for patients. And so getting the balance between these two pros and cons is extremely important. When you look at these numbers in detail, what you'll find is that particularly for the primary prevention patients, so those who've never had a cardiac arrest, the risk or likelihood of having a problem from their ICD is consistently higher than the risk of receiving life-saving therapy. And I think this is a message that we need to talk about in a lot of detail when making these decisions for people. There are lots of different types of ICD. We've also already seen the photograph in the top left here of a transvenous device. So the generator in front of the left pectoral muscle, and in this case, a single wire inside the heart in the right ventricle. The subcutaneous ICD or SICD has been in routine clinical use for more than 10 years now. Here, the generator goes under the left arm with the lead outside the rib cage and under the skin, therefore reducing the risk of long-term lead complications. And coming soon or on the verge of arrival is the Medtronic extravascular ICD. So with a similar philosophy to the subcutaneous ICD, but this time the lead goes underneath the sternum rather than above it, hopefully allowing for a smaller generator size and better battery longevity. But this is a very new technology with lots of data for us to accumulate. As well as the choice of device, it's important to realize that all of these devices can be programmed or set up in very different ways. And this should be personalized. It should be made bespoke to the individual person. So I would encourage anybody who has an ICD or is being considered for an ICD to be involved in that decision. Know your device as much as possible, and just talk with your doctors and your physiologists about how the device can be programmed so that it can give you the protection that it needs, but it has the minimal risk of causing adverse problems. Thank you once again for the opportunity to speak today. I hope that was useful. I think the plan is to have questions later on, but I'm happy to answer any now if that's necessary.
Thank you, Greg. That was really informative and a very comprehensive view of the arrhythmias and the various conditions, and great to hear about all the treatment options. I think we were planning to leave the questions until the question and answer session, because we've got 3/4 of an hour for that. So hopefully we'll be able to answer some questions then. I'd now like to see if Ben is there, if he's able to join us.
Hello, how are you?
Hi, Ben.
Great to speak to you.
Yeah, Angela, do we need to thanks, Greg. Lovely. Thanks, Ben. So you're going to speak about living with an ICD, because you were diagnosed with the condition at quite a young age, weren't you, Ben?
Yeah, so good morning, everyone. Lovely to be here. Thanks, Anne, for obviously inviting me, and then Greg for that wonderful talk there about all the conditions that were sort of facing. You joined me today in under my stairs. I think feel like I should be introduced as Harry Potter these days because I made an office under the stairs, so it suits me more. But anyway, so yeah, I'm here to talk about, I guess, my story around my cardiac arrest, and what it's like living with an ICD, specifically for, I guess, someone of a younger age. So when in 2017, and when I was 12, when I was 17, I was working as a waiter at a restaurant, and as many of, I'm sure, our stories go, as suddenly it's all happened. I was on the ground, so I just walked up some stairs at the restaurant and then collapsed at the tops of the stairs. So luckily, there was a defibrillator in a nearby location at reception. We're all, again, very thankful, I think, for just random ICD defibrillators being in the local areas when we have these sort of events, because we all understand how, I'm sure, how lucky we are to have had one nearby. And so thankfully, my colleagues that were with me on the day were happy to do CPR and get the defibrillator on me, and actually brought me back before any paramedics arrived. And then just as the paramedics arrived, they sort of took over, me being back in a conscious state. I made a whole drama, the event. I was very agitated when I woke up, so I wasn't, obviously, as many of us are, too sure what was going on. And so I did try and fight the paramedics a little bit, but that's just normal in my case. And they eventually got me under control and shipped me off to hospital in an air ambulance, my first helicopter ride, which was nice as well, even though I don't remember it. But so 11 days after the cardiac arrest happened, I was fitted with an ICD. I believe it was a TV ICD, as Greg was saying there. And this was obviously based on the fact that I'd had cardiac arrest, and then I would be, I guess, likely maybe to suffer a further event due to my age and how active, I guess, my lifestyle would want to be as a 17-year-old at the time. And obviously, it was a big event to happen to, I guess, me at that age. But my mentality around the situation, and ever since the situation, has been quite very positive, I'd say, because I was seeing my family around me sort of in the hospital, and I wanted to make sure that they knew I was going to be okay, and that thanks to the quickness and the rapidness of my colleagues and the paramedics on the day, I was able to live a normal life again without really any side effects. I was very lucky in that circumstance to, I've had that treatment from friends at the restaurant straight away that allowed me to suffer no brain damage or long-term effects from the situation. So that does obviously help your mentality when it comes to looking to the future, but ensuring that there's going to be as minimal blockers in the way as possible. But then you obviously have the situation of the ICD being inserted with you, and as an active 17-year-old who was, going to the gym at the time and wanting to explore the world a little bit, being fitted with, let's say, a mini robot inside of me didn't fit on my agenda. But again, I understood that's what it was. That's what was needed to, let's say, keep me safe. So people going through it similar with me with ICDs, or people that might have ICDs fitted in the future, this is a very helpful device and something that's going to allow you to live a much better life than before. We are very protected than most people out there these days. And so although it can seem heavily scary and a big worry, there's so much that you can still do and look forward to. It was interesting to hear Greg speaking about CPVT and being cautious around exercise and stuff, because I still do quite a lot of exercise. I was literally playing tennis this morning. So yeah, it's been interesting to find the balance, and I think I've been very lucky also not to receive any further shocks after my ICD was put in. So 18 months after the device got put in, we found out that I did have CPVT, as I mentioned, through genetic testing, and that's through inherited in the family. So it was also nice to understand, I guess, the causes of it, of my cardiac arrest, so that I could process that myself, and then also balance lifestyle choices based on the serious severity of CPVT and what it can do during exercise and stuff. But again, my mentality that I said from the beginning of being quite positive around the situation has always remained the same, and especially when it comes to sports, living my life and traveling the world sort of by myself in some cases, it's all still possible. So I'm really thankful in those circumstances, and my support from my family has been amazing as well. So, but I can't fault the NHS as well, and the support that I've got through speaking to my specialist and everyone that I've spoken to there. They've really helped in sort of the support structure as well. So again, anyone going through this, or any people that are gonna go through this in the future, you know, the support is at an all-time high, and it's only gonna get better. So we have so much to look forward to in terms of medical advances and things that are going to be able to help us in the future deal with these situations and our conditions. It's only going to get better and only going to be more positive. And it's nice, as Greg was saying, that things are catered towards you, and you know they will take into consideration your circumstances when it comes to putting an ICD inside you. But at the end of the day, it's for the right decision that has been put in. So yeah, it's to be fair, my life didn't change too much when an ICD got put in. I guess I was coming of age, you know, I was just about to turn 18, and wanting to do being an 18-year-old and live my life. So it helped me mature in a different way and helped me look at life very much in a different way, and also brought my family closer, I think, as well. My mom is here. She's rightfully named iPhone, so if you see someone called iPhone, that's my mom. But yeah, she's been amazing as well, and so I hope you all have great support structures around you as well, and look forward to the future, because it's bright for all of us, and you know, nothing can stop us really after we've been through an event like this. So yeah, thank you all again, and lovely to see you all.
Oh, thank you so much, Ben. It's really good to hear that you're so active.
Yes.
You know, it's you know, your positivity. You've been able to carry on, you know, traveling the world and everything, and you're living a really fulfilling life. And Ben, in actual fact, is raising a lot of awareness about sudden cardiac arrest, and he's with us. He's part of he's been to the all-party parliamentary group to speak with the group there to give evidence, and he spoke about his cardiac arrest there, so they understand more what is needed for people who've survived after cardiac arrest. So that was absolutely excellent. So thanks, Ben, for all your help and raising awareness.
And thank you, Anne, for what you do.
Thank you. So I hope Lima's there. If Lima's there, she's.
I am. Can you hear me?
Thank you, Lima. And you're going to speak about whether genetic testing is helpful in defining risks for patients with inherited cardiac conditions. So over to you, Lima.
Before I share my screen, just give me a nod if you can hear me properly. Perfect. Okay. So you can see my screen as well now. I can't see you, so just say yes. Okay, so I chose probably very nicely to follow Greg with regards to talking about genetic testing and how it can define risk in conditions with ICC. Now I chose ICC rather than actually just SADS conditions. So I will touch a little bit upon cardiomyopathies as well in my talk. What I plan on doing today is using a few case studies to highlight messages and show what is available in the literature in terms of using genetic testing to define risk. We've talked about buzzwords already. Gene-tailored treatment or gene-tailored management is something that's quite widely talked about now, and personalized approach to risk stratification, which is what Greg has already touched upon earlier today. But the main thing is using all genetic testing to offer gene-tailored treatment and a personalized approach for risk stratification is we are trying to achieve early detection of genetic conditions, as well as being able to carefully classify these variants with expert guidance. And I will touch upon that as well. So I wanted to start off with some basics, to be honest, because I'm not sure how much of genetics everyone in the audience here knows, but there are two main types of genetic tests that we offer. And the test is just a simple blood test, to be honest. And we take the DNA and we look at the genes. So as you can see, I'm not much of an IT person here anyway, but thank you for guiding me through that. So coming back to the type of genetic testing, so diagnostic testing, as I explained, is actually when the person is affected and you are looking to confirm their clinical diagnosis. Predictive testing, on the other hand, is actually testing a family member because there is a mutation that's known in the family and the person is unaffected themselves, or perhaps has not had clinical screening yet. And you're testing them specifically for the mutation that's known in the family. And part of the reason for doing this is to have an early diagnosis in them and monitor them carefully over a period of years as well, because they may develop signs later on rather than at initial assessment. So I'm a geneticist, so I work a lot with all conditions involved in ICC. So I chose iotopathies because that's something that I often deal with in clinic. There are several genes that are involved in iotopathies, and gene-tailored management in this group of disorders is fairly well established now. If you have a condition called Marfan syndrome, we know that there is an iotopathy, or the aortic root is involved. The outcome of surgery is actually quite good with that as well. And medical treatment with both beta blockers and ARBs, such as irbesartan or losartan, is actually well established now. And we also have much more tailored surgical options that we can offer for these patients as well, because we say surgery roughly when it's around 50 millimeters is probably more appropriate for Marfan syndrome. On the other hand, vascular EDS associated with misprints in the COL3A1 gene involves all the arteries, and it's often referred to as a medium-sized arterial disease. And the arteries outside the aorta are also involved. Actually, medical treatment now with both losartan and celiprolol is actually considered more effective with this condition. And surgical treatment is not that helpful in this group of disorders. So more conservative treatment as much as possible is encouraged. Lois-Dietz, on the other hand, again involves both the aorta and arteries as well. Both beta blockers and ARBs are effective, and surgical treatment, however, is at lower thresholds when the aorta is around 45 millimeters rather than 50 as with Marfan syndrome. And then there's this group of disorders called the familial thoracic aortic aneurysm and dissection, where everything is variable and we do not have enough data, and we are working on that group of disorders. So just to keep that in mind, I just wanted to bring it back to a case so that we can start discussing about how genetics actually helps in risk stratifying, or in kind of giving more information for the family as well. So the three cases that I've chosen are pretty much ones that we have come across in the last few weeks in our service. So so although they may not be totally relevant to the whole talk, I thought it would be good to start off with scenarios that we often deal with. So an exercise enthusiast, runs multiple marathons, does 100-mile cycling routes every week as well, came in with a recent syncopal episode on discussion. It sounded very vagal, that's how it was described by our cardiologist, but investigations such as an MRI and ECG showed clear features suggestive of ARVC, and he fulfilled the task force criteria for a diagnosis of ARVC as well. In addition, he was the only person in the family who was affected. There's no significant family history that was of relevance, and he was planning to start the family, so keen to understand implications for himself and to his family as well. So I start off with this paper from 2021. They looked at around 856 patients with a mean follow-up of around 5.7 years, but it's around 2 to 10 year follow-up. And they used 8 clinical predictors to see whether those will give enough information in terms of risk prediction for life-threatening left ventricular arrhythmias, LTVA, as they have shortened it here. Genetic testing or mutation presence did not present as a major feature in this study. And as you can see, the conclusion from the studies shows that the 4 predictors that were of relevance in ARVC was younger age, male sex, burden of ventricular ectopy, as well as repolarization abnormalities. They did a small comparison of patients who had PKP2 mutations and did not have PKP2 mutations, and they noticed almost no shift in the predictive effect. So carrying on from that, they actually did a model for risk prediction in ARVC, and this model, as you can see, actually shows the features that they described in that paper as well, which is age, sex, recurrent syncope, and the presence of non-sustained VT as being the main features which will add to their risk calculation. So if you look further, whether genetic testing actually is helpful in ARVC and how does it help, there is this paper from 2022, which involves patients with the Netherlands Arrhythmogenic Cardiomyopathy Registry. They looked at patients who presented initially and family members. And in the patients who presented as probands, what they did is added genetic testing to the task force criteria, and then did analysis. And what they have identified is if you remove genetic testing from the task force criteria, around 11 patients actually lost their diagnosis. So they did not have a clear-cut diagnosis of ARVC, which they summarized as 5%. And around 21 patients, there was a delay in their diagnosis. That's around 10%. And what they also noted is that none of these patients actually had a significant amount of ventricular arrhythmias, and they call it malignant ventricular arrhythmias here. That's why it's shortened to MVA. But a small percent, 1% of their total cohort who had a delay in diagnosis actually experienced ventricular arrhythmias during the delay for genetic testing. When you look, so this is the probands, which is diagnostic testing, but when you come to relatives, this is the predictive testing that we're talking about. Again, removing genetic testing from the task force criteria led to a loss of diagnosis in around 4% and a delay of diagnosis in a small number of cases. And none of them developed ventricular arrhythmias. So based on this, they actually said that age at presentation, male sex, and the pathogenic variant associated with ARVC probably does give information that is of relevance. When we talk about genetic testing, one of the main things is we have to be careful about how genetic testing is interpreted, and working closely with your genetics colleagues is something that we would recommend. Even if you don't look at the top table, focus on the summary points. The main findings were that quite a huge amount of the genetic variants had to be reclassified when the data was looked at properly, especially with application of recent ACMG guidelines as well. And what they also noticed was PKP2 genes were less likely to be reclassified when compared to other genes. But I think what's more important is the ones that I've highlighted there, which is around 10% of cases who had been initially thought to have a good going mutation causing the disease had to be downgraded to borderline or possible. So the diagnosis was taken away from them from the genetic aspects. And similarly, in family members, there were variants that were initially identified and thought to be pathogenic, and family members were tested and reassured to kind of say they no longer needed any further investigations, had to then kind of, have the information changed for them because of this reclassification. So one of the things that has recently come about in our practice in clinical service is with ARVC in particular, even when predictive testing is undertaken, we often ask for clinical screening as well. And in some cases, even though they do not have the misprint that is known in the family, we do sometimes recommend, depending upon the family history, for cardiac screening every 3 to 5 years, even if they are asymptomatic, and just because of the lack of confidence in the genetic changes. And this is particular with ARVC, it's not with other conditions, and I wanted to highlight that as well. So in this ARVC case, so he's an enthusiast. So what we did is we did test him. He had a DSG2 mutation, and it was a good going class 5 mutation. And we then went on to screen family members with clinical screening as well, and take and also refer him on to have a discussion regarding PGD, because he was keen to have a child without having ARVC. So he is undergoing that process at the moment. So this is a SADS case, a young couple who came to us. They are very distantly related, so they're consanguineous, not immediate first cousins. They've had 3 pregnancies. They have a girl who is well at age 6, a boy who died at 18 months, had multiple seizures and heart rhythm abnormalities, and they are currently pregnant. When we initially saw the boy, we didn't know about the heart rhythm abnormalities. He presented a sudden death, and the prior history was that he had multiple seizures. And we had genetic testing undertaken for him in a much more wider panel called the R14, because we didn't know what the cause of death in this individual was. That's a panel of genes that we look at. And then had a diagnosis as a result of it. So the parents particularly were keen to understand the risk to the current pregnancy. They wanted to know why the child passed away and what they should be looking out in all their children. The couple themselves were fit and well, and there was no significant family history, but because of the dynamics of the family, they may not have been fully aware of medical problems in the wider family. So Greg has touched upon a lot of this, so I won't go into a lot of detail, but one of the things that is quite clear, and this is a paper from looking at 101 pediatric patients with long QT, is that if it is long QT2 or long QT3 genes that are involved, then there is a definite additional risk in terms of events when compared to when it is just long QT1. And specifically, if the misprint is in this particular region of long QT2, which is in the pore region, then the risk is of events is actually slightly higher, which is probably really well described in this pictogram here. So this is a wild type where everything is normal. This is when there is heterozygous misprint in the gene, causing a haploinsufficiency where the gene is not working or is only functioning to a lesser level than when compared to the normal or the wild type. And there is this type of mutation effect, which causes a dominant negative effect where there are damaged parts of the gene, and therefore but it is not a reduced function. It's called dominant negative effect. And this is actually a much more significant risk for events when compared to even the haploinsufficiency type of misprints in the gene. So even in one gene, the type of misprint can cause a difference in risk in terms of events that can occur. So working closely with your geneticist becomes much more important, and learning more about the misprint and the type of effect that the misprint causes also is important. I like this graph, which was very simple. Greg has given several other graphs for you to as reference as well. But this one actually says if you are a long QT1 with being a male, probably carries your a lower risk when compared to being a female. And if you are long QT2 or 3, then this carries a much more higher risk. And again, they've also highlighted in this chart that there are misprints in particular areas of the genes called the loop mutations, or in the poor regions of the long QT2, which are actually much more higher risk. And I just wanted to describe this as just to give you a little bit more understanding of how we are looking at genes and conditions. So when we talk about single gene disorders, we're talking about Mendelian inherited, so autosomal dominant or recessive kind of disorders. And we then talk about oligogenic, where there are multiple, causes that may be associated with a particular condition. And as you can see, long QT, CPVT, and hypertrophic cardiomyopathy fall under this end, where finding a genetic explanation is much more easier. Whereas if we talk about Brugada and DCM, the single gene effect may not be as clear. And there is even with Brugada syndrome, it's well described now, even with a misprint in the SCN5A, there is lack of correlation with the clinical phenotype in some families as well. So in this end, what we are talking about is there are rare variants, but maybe there is accumulation of susceptibility variants that actually are important and something to keep in mind. And the case that I highlighted today probably adds more information to what I'm trying to express here as well. So in this particular case, what we have noticed is that they actually had a homozygous SCN5A mutation. So the child, the boy who died, had 2 misprints in both copies of his genes. Well, 1 misprint in 1 copy of his gene, and his parents were heterozygous. They had 1 copy in their gene. And what we are now what we are well aware of now is the accumulation of susceptibility mutations in SCN5A causing a more severe phenotype. So the young boy, because he had 2 misprints, presented much more early with much more significant phenotype, whereas his parents did not have any clinical presentation, but on investigations, they did have positive atumelin tests. So the couple were counseled on the basis of this. Here, it will almost be a recessive risk for a severe phenotype, but also a dominant risk for having heterozygous mutations as well. So, so they were carefully counseled by the genetics team with regards to what options would be available for them. And going back to that case, the current pregnancy was also a male fetus, and they decided on testing that pregnancy or the child after he was born with cord blood, so that we can plan for his management early on as well. So moving on to dilated cardiomyopathy, this is another case who presented quite recently to our wards with young onset heart failure at 16. He presented with an out-of-hospital cardiac arrest. While taking his history, we noticed that he may have eye features that were suggestive of retinitis pigmentosa, and he was awaiting an ophthalmologic opinion. And he also had delayed puberty, the cause of which was not known. So we looked through to see if he had any neuromuscular features or any metabolic abnormalities in his investigations. In the family history, there was just this father, maternal grandfather, who passed away at the age of 40 with a possible cardiomyopathy. The intervening relative, his mother, was well, and there was no other family history. So this is a study done by the RBH group, and Brian, who's one of our colleagues at GSTT, was involved in leading this study. What they looked at is what is the confidence that is added to a diagnosis of dilated cardiomyopathy when we add in both genetic testing as well as imaging results. And one of the things that was highlighted in this study specifically was that there was a lot of changes in management once the patient was fully investigated in around 28% of cases. And in majority of them, the management changes were in relation to a recommendation of screening in family members. In a small percentage, device therapy also, recommendations were also changed. Medical therapy was intensified in a small group of patients because they were identified as risk. And lifestyle advice was also slightly different. But as you can see from basic assessment, adding in genetic testing and CMR actually has given a difference in terms of the confidence levels in making a diagnosis of dilated cardiomyopathy, which is idiopathic dilated cardiomyopathy, and ruling out other causes and risk factors for cardiomyopathy. This is a study that was a review, maybe more than a study, I should say, done in 2022, where they were using risk stratification for sudden cardiac death in individuals with the DCM, and this is part of the Reconsider trial. And basically what they say is there are several spectrum of DCM phenotypes, and they need a multifactorial evaluation, which includes clinical, imaging, genetic information in addition to be able to identify risk in these individuals. But in day-to-day practice, what we often notice is that from the genetics aspect, identifying which gene is involved in dilated cardiomyopathy becomes quite important, because there are specific risks attached to a particular gene. For example, people with lamin and people with perhaps desmin or FLNC can actually have a higher risk of heart rhythm abnormalities, and therefore will probably be counseled in a slightly different way in terms of devices when compared to a person who has a misprint in, let's say, MYH7. So the role of genetic diagnosis specifically in identifying the high risk genes that are associated with dilated cardiomyopathy and the increased arrhythmic risk as a result of this are important to identify in this group of disorders. So in this young individual, he was actually a phenocopy. He actually had widespread pigmentary changes in the retina. He had a different type of test. He had a panel test as well, but he had a test where you looked at the chromosome dosage. And we identified that he had a deletion in the long arm of chromosome X, and there were two genes that were involved, LAMP2 causing Danon disease, which is probably the explanation for his heart failure, as well as the CUL4B gene, which is probably the explanation for his delayed puberty as well. And interestingly, he was mosaic, so not all his chromosomes actually had this deletion, only some of them had, that is around 20 to 30%. And that's probably why he did not have the full-blown features of Danon disease that we probably are much more adept at picking up. So in conclusions, what I wanted to say is testing to confirm the genetic basis is beneficial in risk stratification. It probably helps in identifying at-risk family members, confidence in clinical diagnosis. It influences management advice. We are increasingly getting MDT discussions about this person needs an ICD, has a cardiomyopathy or a long QT, and actually knowing what the gene is before we make that recommendation for ICD sometimes is helpful. And how we arrange follow-up for these patients and screening intervals is also helpful. So it definitely influences management, and therefore requests for rapid testing often, so that the tests are prioritized and actually come back sooner, is made. So personalized follow-up regime, as I said above, and counseling based on the specific gene and mutation-specific data, as we talked about in long QT, is probably also important. But I think what's more important, which I put in brackets there, is that you have an integrated genetics team to input into your management of patients, rather than expecting a cardiologist to be fully well-versed in genetics, or a geneticist to be fully well-versed in cardiology. So having a team, an ICC team that actually has all components of medical expertise is perhaps much more important. Thanks, and I'll stop sharing now.
Thank you. Well, thanks very much, Lima. That was a very informative and comprehensive presentation. That was absolutely excellent. So we just got to stop the sharing the screen.
Yeah.
Lovely. And I'm now hoping that we can pass over to Dr. Silvia Priori from the University of Pavia, who's going to speak about SADS conditions and a sneak preview into tomorrow. So thank you, Silvia.
Thank you very much for your introduction. I'm always very glad to be at the SADS meeting, because they are really a great opportunity for us to hear the perspective of the world and the patients around the world. So the task that has been given to me is actually very exciting, because it gives me the opportunity of share with patients and other colleagues the concept of what we are going to see in terms of changes of the management of our patients. And there are indeed some very exciting news that I will share with you. So first of all, just to give you an orientation of the many potential topics that one could deal with talking about the future, my presentation will be centered around the promises of gene therapy, because gene therapy now is really around the corner. We started working for developing gene therapy for inherited arrhythmias in 2010. Our first paper came out in 2012, and at that time we didn't really have any clue on the speed of this introduction in the clinic. But now finally I think that we have to say that the field and so many groups have collaborated in developing very innovative and interesting gene therapy strategy, that finally we are 1-2 years from the time in which we will see the first clinical trials coming up and giving patients the opportunity to be involved in these therapies. So in the first 2 slides, I just want to give you some basic information that will allow you to understand better, when I will talk about each therapy for a disease, which strategy has been used. So basically, gene therapy is about modifying or manipulating the expression of a gene, and therefore the related protein, or modify the biological properties of living cells. And this is especially the cell therapy, what we call the cell therapy, that modify the cells. And the expectation that we have from gene therapy as compared to therapy with small molecules, that is chemical products, that is what we have been seeing up to now, is that manipulating and modifying the genes, that is where the cause of the disease is located and where precisely the mechanism is generated, that there is the possibility to really approximate the concept of being cured. So these therapies have the potential of moving to a next step where we will be able to remove the arrhythmogenic substrate in the case of channelopathies and cardiomyopathies. And we can do this by knowing that most of the genetic diseases are about a gene that carries a mutation that reduces the amount of a protein, or that the gene has a mutation that modifies the function of the protein so that the protein becomes pathologically overactive. And so we have in nature two perfectly fit mechanisms that are already there, because we know that our cells are intelligent, and if they perceive and understand that one protein is missing, they activate elements to try to increase the amount of the protein back to normal. Unfortunately, these approaches can ameliorate the phenotype, but cannot really resolve it. But we can be inspired by what nature wants to do and try to do it completely and better. So for those conditions in which we have the so-called loss of function mutation, there is the possibility to take an adenovirus, adeno-associated viruses, remove the part of the nucleic acids of the virus that is making the virus unable to replicate, because when the virus enters in a cell and start replicating, it will lead the cell to death. So we can remove the nucleic acids and the genome of the virus and instead put in the DNA that will help to produce the missing protein. It seems a bit more challenging how we can mitigate a condition in which we have an increase in the function of the protein. But again, nature has a very intelligent mechanism that is called RNA interference. RNA interference is based on the concept that there are very small fragments of RNA that can be used and are actually used by nature to turn off the production of a protein that is not functioning well or that is overexpressed. And so this RNA interference will also become a tool that we can, in the same way as we did for putting in the DNA of the protein that is missing, we can put a little piece of RNA that is going to reduce the amount of the protein that is overfunctioning. And so it's just an accelerator and brake kind of two strategy. You can visualize them in that way and are able potentially to cure and to treat with a gene therapy strategy most of the conditions that we have. So here we see in graphic form gene augmentation. So there is a cell with a loss of function, so protein X is missing. Okay, we take and we put in our virus the DNA for that protein, and then the cells will gain the corrected function. Similarly here, we see that the cell has a function that is increased by a gain of function mutation. Then we have to do some work. We have to screen and find in vitro which is the sequence of an RNA molecule that will be able specifically to reduce the transcription of the allele that has a gain of function mutation. And then again, that could be a resolution of the phenotype of the patients. Then there is another strategy that is really very advanced that is called genome editing. Genome editing can use methods like the very famous CRISPR-Cas9 that is able to modify the sequence in a gene and therefore can result in correcting and so bringing back to normal the sequence of a gene that has a mutation that changes the function of the gene itself. So most of the therapy that are becoming ready soon are either gene augmentation or gene suppression. And there are some technical reasons why that is, but a lot of groups are still working on the genome editing as a therapy that maybe will come a little bit later, but holds great promises. So one point that I want to raise is that in gene therapy today, the trials that have been performed, not cardiac trials, because we have had only one trial directed to the heart for treatment of heart failure, and that has been the CUPID study. The CUPID study was overexpressing a calcium regulatory protein to modify the deficit of contraction in patients with heart failure. But in this case, heart failure was not related to an inherited cardiomyopathy. So there was more than one abnormality, as it is the case in patients with acquired disease. So that trial didn't result in being effective in rescuing the phenotype in the patients, but sent a very important message, that was that giving a therapy with an adeno-associated virus to human being did not cause side effects that were lethal or very severe. So that has been really an incredible, important first step for moving toward a future that is now getting very close to us. So some time was dedicated to decide whether we wanted to use a virus or we wanted to use nanoparticles. Nanoparticles are a round circle-like vesicles of a protein of a lipid shell in which we can put our viruses, or in which we can put the molecule that is the therapeutic one. The problem of the nanoparticles is that they don't know where to go. So they can go potentially in every cell of the organism. And that could be a problem, or just a reduction of the therapy that becomes available, in our case, to target to the heart. The major advantage in using the viral vector is given by the fact that we have now viral vectors that have been modified in their external portion so that they become particularly prone to localize to the heart. And these are called adeno-associated virus type 8 and type 9, and in particularly the 9 has been very much studied. So it's very valuable, very precious that science has gone to the point where we have a specific container that will allow us deliver our gene therapies to the heart. I just want to mention that the major concern that nowadays exists about gene therapy is the concept of the immune response. In fact, sometimes in trials, it has been used therapy that reduces the level of the immune system to try to avoid this immune reaction that can diminish the efficacy of the therapy or create side effects for patients. So the adeno-associated virus seems to be the way to go. Is safe from several perspectives. For example, it cannot really start replicating because it needs a helper virus, so a second virus, to become able to replicate. The infection with AAV is not associated with disease in human. Therefore, all of us, at least is documented that more than 50% of the population has contracted a contact with an adeno-associated virus. And in fact, we have to be careful that the patients do not have very high levels of antibody to the adeno-associated virus that is used to deliver a gene therapy, just to avoid that these antibodies that we develop when we encounter without even knowing, because it's not a virus that creates a specific disease, it just gives some non-specific symptoms of the flu-like type. So the patient should not have this antibody at a very high level. And then, the fact that we have learned that the viruses target to a specific region or a specific tissue or specific organ because of the characteristic of their external layer, has now created a very active research in developing new viruses that will specifically go in what we are interested, for example, that will go specifically to the heart, and that are new. So people will not have previously existing antibodies. So as you see, you know, there are obstacles still, and there are concepts that we would like to use to improve the gene therapy, in particular with the delivery, and in particular to reduce the possibility that patients have already the antibodies and therefore will not be great candidates for these first gene therapies that will be based on viruses that are present, and therefore we may already have antibodies for that. After this part that I understand was a bit complicated, but I wanted to give you two things. You know, one, the concept that there are still things that we are optimizing by the time this therapeutic molecule will come to the clinic. Hopefully all these will be addressed. And on the second time, that research is continuing to making the gene therapy more precise, to go only to the organ that require being fixed. So, of course, patients know very well that the problem with current therapies, even when they are effective, is that they require a lifelong intake and may prevent arrhythmias, but not reduce the risk really to the larger extent that is what we expect from gene therapy. None of the currently used therapies is 100% effective in preventing the arrhythmic risk. We will hope that gene therapy, if not 100%, that in medicine doesn't really exist, because there is always a patient that is less effective responder, but that we will be able to raise the percentage of patients that respond and that will be able to be freed from taking medications. Of course, at the beginning, trials will be done with other medications on board, possibly, you know, just not to put patients at a risk, or with the patients that have the defibrillator implanted. But it's very important and very exciting that these first steps will be made in very short time at this point. So I'm going to present you what we are doing and what we have done in the gene therapy. And we have targeted at the beginning catecholaminergic polymorphic VT. Our decision was we want to start with conditions in which we know that patients do not have therapies that are extremely effective, and that often we have to combine more than one therapy to control their arrhythmias. So we started with the recessive form of CPVT because we had a clear strategy. Of course, you know that CPVT, the recessive form, is caused by a gene called calsequestrin that creates this protein, calsequestrin protein, that binds calcium inside this structure that is called sarcoplasmic reticulum of the cell. The important role of calsequestrin is that it is also a regulator of this big structure that is the ryanodine receptor that has already been mentioned during the previous talk. The ryanodine receptor releases the calcium from this area that contain a lot of calcium, and the calcium released by the ryanodine receptor is the one that allows the heart to contract. So very important team, calsequestrin and ryanodine receptor. But do not forget the concept that I have said, that calsequestrin modulated the ryanodine receptor, and specifically it stabilized the ryanodine receptor to be closed when the heart is not in need of being contracted. So during the so-called diastole, that is the relaxation phase of the heart. We will go back to this concept. So first of all, we used the strategy of saying, okay, our patients with catecholaminergic recessive due to loss of calsequestrin really have low levels of calsequestrin. So our mice that mimic the disease have the same phenotype, loss of calsequestrin leading to cardiac arrhythmias. So the therapy should be for these patients, putting the gene that encodes for normal calsequestrin inside an adeno-associated virus. In this case, we use serotype 9, and deliver this to the mice. So here is how we build the construct. And here I introduce you to Marco De Negri, who has been the scientist, a PhD, working on the development of this therapy. So we have the calsequestrin sequence. we have a green tag that allow us to tell which are the cells that receive the therapy and the one who do not receive the therapy, so that we quantify which percentage of the heart has been treated. And then we have our adeno-associated virus type A. So what we did was to deliver the therapy to mice that have zero calsequestrin, so the most severe form, no calsequestrin at all, and so with mice who have a mutation R33Q that is present in some of the families we are following and in families that are around the world. This is a mutation that is relatively common in Cas2 disease. And so we know that also patients with this mutation have calsequestrin, but the fact that there is the mutation, this calsequestrin doesn't work well. Why we gave the therapy to newborn and adults? Because we wanted to see whether a newborn treated would never develop the disease, so would be a preventive therapy, and then adults that already manifest the disease would be rescued and will no longer show the phenotype of the disease. So behind producing arrhythmias, the loss of calsequestrin creates some changes in other proteins like junting and triading. Enough to say that you have the mutation in the gene for one protein, but as a result, you reduce the levels of 3 proteins. So what we wanted to see as a first effect of our therapy in the mice is that giving more calsequestrin would rescue also the loss of these 2 other proteins. And we see here that the animal treated, instead of having reduction calsequestrin, of course, normalize it. This is what was contained inside the virus. But once calsequestrin level were back to normal, also the other 2 proteins got back to normal. So we ticked the box for step 1. We were able to rescue one alteration that is caused by the loss of calsequestrin. Then we also know that the calcium, instead of propagating in nice regular waves, in calsequestrin are unable to make these waves. So we wanted to see that cells that have received the therapy were back able to have nice waves of calcium that are important for the life and function of cardiac myocytes. And here we see that treated myocytes, instead of having these chaotic flashes of calcium, they had nice, well-organized waves similar to the wild type. But of course, what we wanted to see more was that we were able to block and never have and never see again, even during catecholamine infusion, the bidirectional VT that is typical of patients with CPVT. And here we see that after the treatment, the animals, even in the presence of catecholamine, did not develop anymore the therapy. These animals, before treatment, 80% of them, every time we give epinephrine, they develop the bidirectional VT. And here you see that this effect was maintained at 6 months, so that the reduction of arrhythmia was very strong, and 9 months and at 1 year was still there and present. So I have to say that we were very, very, very proud and very happy of the results of this therapy. And we were very proud that they were not only effective in this mutation that give some reduction of calsequestrin, but that they were even effective here in patients, in mice, who had 0 calsequestrin. So these anticipated that the therapy might work even in patients that have deletions of calsequestrin that get very close to the phenotype of what we make in a mice that has 0 calsequestrin. So I told you to memorize that calsequestrin is also important for keeping the ryanodine receptor close. So here we got the concept that in the dominant form of CPVT, the problem is a gain of function, so over too much effect of the ryanodine receptor, that is this large calcium channel that I have shown you before in the graphics. And the problem of the mutations of the ryanodine receptor is that this channel remains open also during relaxation of the heart. That is not the right moment to be open. So there is an excess of calcium that goes in the cytosol, goes in the cell, and creates the arrhythmias. But then we reasoned, if calsequestrin normally calms down and closes the ryanodine receptor, maybe all we have to do to the patients with mutation in the ryanodine receptor is to give them a bit more calsequestrin than what they have and see whether that would allow the ryanodine receptor to close and abolish the arrhythmias. So what we did was really to exploit the fact that calsequestrin stabilizes the calcium release and inhibits the opening of the ryanodine receptor. And then we decided to do the same thing and put wild-type calsequestrin, so exactly the same therapy that we will propose in the clinic for patients with the recessive form, can be given at lower dosages because the patients with ryanodine receptor mutation already have a normal level of calsequestrin, to add that little bit that is required to counteract the excessive opening of the ryanodine receptor. And here, I just want to go to the results on the arrhythmia and show you that we tested different doses, a lower dose, a mid dose, and a high dose. And we did this because one aspect that is very important is that we need to aim at identifying the minimal effective dose, because of course, if we use the minimal effective dose, we may reduce the side effects when we go to the clinic. So what we observed is that low dose, mid dose, high dose were equally effective in reducing the arrhythmias. So the arrhythmia went from a lot of arrhythmias in the animal with the mutation in the ryanodine receptor, but after the treatment already at the low dose, the arrhythmia had disappeared. Here, I was a little bit unhappy. I said, why at the mid dose, I need to have one animal that gets some arrhythmias? So we went to measure how much virus had reached the tissue and the organ of the heart. And we notice here that this animal, that is this one who had the arrhythmias, at the mid dose did not receive the therapy because the experimental person who did this injection made it wrong. And so there were actually no trace of the virus in the body of this animal. So we were very reassured because all the other had responded and didn't have the arrhythmias. So the therapy works very well at different dosages, but the exciting one is that it works perfectly well in the mice at this very low dose that we hope, would be the dose that we could use in the clinic. Of course, not exactly this number, but this number calibrated for an equivalent for a human being. And so also this kind of work, kind of therapy worked, and we are very excited that the same therapy can work for the two types of CPVT. So before starting a clinical trial, we will need to be sure that the patients will not have the antibodies to attack immediately the virus. We need to be very able to identify the minimal effective dose. And we need to think about strategy for immunomodulations, like giving cortisone, for example, at the time of the injection, or other strategies that are being tested in different trials, to be sure that in the post-dosing, after having received the therapy, no immune response will occur. And now we go to an exciting therapy, and we have data that have never been published yet, but are extremely exciting. And I wanted really not to miss this opportunity to show them to you. And it talks about treating, sorry, I need to go back. treating Timothy syndrome. And I was very happy to hear that Catherine Timothy, that gives the name to this therapy and not to this disease, and not only to this disease because she was there, because she has really made an enormous contribution in identifying, categorizing these patients, defining their phenotypes and their, I'm sure you know, very severe outcome and risk of arrhythmias. I had promised to Catherine that I would have worked for a disease like Timothy syndrome. Despite it's a very rare disease, these patients really need a gene therapy to treat them. In the study by Igor Splavsky and Catherine Timothy, the average age of death was 2.5 years in the children with Timothy syndrome. So we really have to do something. So we put all our energy, and I wanted to hold my promise to Catherine that we would have worked for this set of patients. So here you see the prolongation of the QT, the T-wave alternance that you know is a manifestation of electrical instability, and the arrhythmias that occur in these patients, together with some other manifestation like facial dysmorphism, very thin hairs, and syndactyly, that is the most typical and best known, of the toes and the fingers. Syndactyly means that two fingers are attached one to the other. And the patients with Timothy have only skin that is attached, so the fingers can be separated, and this abnormality can be fixed. The problem is how we can fix the abnormality in the heart. So I have taken the picture of Catherine Timothy from the previous speaker. I hope I'm allowed to do this, but I didn't have one. So we know that Timothy syndrome is caused by a genetic mutation in the cardiac calcium channel. We are very convinced that calcium is a major culprit of arrhythmias. And so we worked in a disease with calcium regulation abnormality. And here we have a second one. So the calcium channel is made like all the calcium channel. It looks like a donut with a hole. And in the hole, we have the movement of the ion that is specific for that channel. In this case, is the flow of calcium that is affected and that is modified. The disease is caused predominantly by one mutation, this mutation that replaces a glycine with an arginine at position 406. So if you put all the amino acid in a line, you go 1, 2, 3, you count all of them. When you get to 406, you will find the mutation that is present in this protein. And the presence of this protein that is modified, alters and prolong the QT, but prolong it very, very, very much. So this case is again a case of a gain of function. Gain of function because the calcium channel opens and then is unable to close, a little bit like what I said about the ryanodine receptor. So what one could do is, again, design a molecule of RNA that is able to reduce the amount of the mutant protein, but without touching the wild-type protein. So this is a dominant disease. So there is one allele that has a normal coding for the calcium channel, and the other one inherited from one of the parents or just modified during embryogenesis only on one side. So it's a perfect condition for testing RNA interference. It took quite a lot to identify a molecule, not much that was able to silence the mRNA that was carrying the signal to produce the mutant protein, but to make it selective to silence only that one. And I have to say that Rossana Bongianino, the scientist in my work, she worked more than 1 year to identify the right molecule to achieve this result. But we wanted also to make another step and another advancement that now we believe will become something that should guide our pathway in development of gene therapy. That was to apply for funding to the ERC, that is the European Research Council, that gives money to scientists who have a challenging project. Challenging means very difficult to achieve. So we proposed to them that we had the need for Timothy syndrome patients to develop not a mouse model, but a pig model, because we really wanted to see whether we could correct not just the mutation aesthetically and have it there, but we wanted really to prevent the substrate. And to prevent the substrate, we need to study the heart of the model in which we are testing the drug with the same tools that we use to test the patients. And that is done by electrophysiological tools that are called electroanatomical mapping, where we can map the heart and see whether the arrhythmic substrate is there or it has disappeared. And then the other challenge of this project was to identify the right silencing molecule made of RNA that was precise for this, leaving intact the wild type allele. So it has been a collaboration that has lasted 5 years. In 5 years, we have developed our animal model. We have had my group in Italy and my group in Spain to collaborate with different competencies, different expertise, but just one commitment for all of us. We need to do something for Timothy syndrome. So in our animals, we've demonstrated that these pigs have a very, very high mortality, as you can see here. They have an 80% arrhythmic mortality, and these approximate what is seen and reported for the patients with Timothy syndrome, as you can see here for the Kaplan-Meier. So just what we do in patients that is using loop recorder, we implanted loop recorder to see whether the mortality that we see in the pigs were arrhythmic mortality. And here we go. An animal that goes in ventricular fibrillation. And we have documented that all the sudden death that we have are exactly like the sudden death of the affected patients. And the electrocardiogram looks remarkably similar, with this ST segment elevation that is prolonged and very much prolonged, like the LQT3 in a sense. So we were also able to induce ventricular arrhythmias in these animals using programmed electrical stimulation. And so we were now in front of a model that was also inducible. So at variance with long QT syndrome type 8 mice and rabbits that were not inducible, we had an endpoint to see whether our therapy could really be effective. So our endpoint were if we were able to shorten the QT, if we were able to prevent the arrhythmias. But more important than shortening the QT is to modify the arrhythmic substrate. Some of the studies were done in isolated cells, because in the isolated cells, we wanted to document that the channel that opens and never closed now was able to close. So that was step number 1. So this is the heart that gets taken after the animal is dead and is superfused. So we put liquids to remove the blood, and then we put enzymes that isolate the single myocytes. And then with this apparatus that is called a patch clamp, the scientist is able to put a glass pipette and measure the current. And so normally the current is like this. It opens and then it closes and becomes quite small by this time. In Timothy syndrome, the channel opens, the current is here and never really reduces like this one. So this is why calcium continues to enter inside the cells. So we did our therapy, we put inside the RNA molecule, we put some color because we wanted to see that the cells that have received the virus and were cured, we hope that that would be the signal. Green, we put it green because we were confident that the cells that would get the virus would become normal. And then the red was a signal that would represent the cells that were not infected and not modified. This is the identification of the molecule that was the best one. That was the molecule that we call the A6. And here you can see that there are myocytes that are green, that we can say, okay, these cells are green because they really have received the therapy. And so we now go and measure them and confront them to the cells that are not green and have not received the therapy. Other screenshot of the cells. So here you see that the cells that were not green never really went back. Cells that were somehow green already got much better. You see that this goes to the red line, the baseline is here, quite rapidly. And then the ones that were even more green really got back to normal. In parallel with this, we also had a shortening of the QT, of course, because the QT is prolonged by this calcium that remain open. We have now done experiments to show whether the arrhythmogenic substrate is present by mapping the heart. And these are slides that I cannot show you because they have never been presented anywhere and not yet published, but we are preparing a manuscript right now. But I hope you take my words that the heart look absolutely normal and fully restored. So we are extremely excited that this is not only the advancement for a disease, but is also a proof of concept that when we can have models that they have a heart not of 2 grams like the heart of a mouse, but really the heart that has the same shapes and feature of a human heart, we can really make those investigations that can prove to which level and extent our cure can go. And then I just want to mention, for analogy, another concept of the importance of investigation of pigs, because you might have heard that pigs' heart are very similar to humans, to the point that there is now a very strong and international collaborative activity. I am not participating, but because it's not my field, but I'm actively monitoring what is happening. That is to genetically modify the heart of the pigs so they can be tolerated and transplanted into patients. This could be an excellent solution for the lack of hearts for patients, for example, with inherited cardiomyopathy that degenerate to the point that the patients need the transplant. Very often the wait for a suitable heart is very long. So I am showing this from the New York Times to underline that the first man individual has received a heart from a genetically modified pig. And this is called xenotransplant, that is transplant not from the same species. And you see the excitement of science, a door that is finally open, pig to human heart transplantation, who goes first. And this is something that is very similar to gene therapy because, again, is about manipulating the genome of an animal, the cardiac expression protein, and especially make it tolerated by the immune system. And so with this, I want to conclude and say that gene therapies, cell therapies, xenotransplants are the revolution that is called of biological therapies. We are using not chemicals, but modification of genes, modification of cells, and now even modification of organs. And we think that this perspective will really make a jump forward that will benefit patients with inherited diseases and acquired diseases. Thank you very much.
Thank you very much, Sylvia, sharing your extensive research there. It's very, very interesting and such a lot of work, very, very complex for someone like myself to understand, but it's great to hear that it's going to help patients in the future. Absolutely amazing. So thank you for that. And I'd now like to invite all the speakers to come back because I believe we've got some questions now. Let's see if I can find some. Looking at the questions. And I'd also like to invite Professor Devendra Kumar for joining as well. looking on the questions here to see what we've got. Someone has asked, please could you explain a bit more about the health effect that the gene PKP2 produces, including kids, and how aggressive it can be? I'm asking this because they have detected the mutation of this gene in me and my child. So I don't know if that's something that Sylvia, Devendra or Lima might be able to answer.
And I think I replied to the message. I think it was Anna who actually asked that, saying PKP2 in general is actually a little bit more variable when compared to as in how it presents when compared to other desmosomal genes. However, without knowing what the mutation is, it's actually slightly difficult for us to give advice. So I've asked whether she has met with a geneticist in her ICC team so that they can look at the mutation in more detail to be able to give her answers.
Oh, that's good. Oh, excellent. Yes. Yeah. So some of these questions look like have been answered, but it might be nice to repeat some of them so that other people watching will learn a little bit more. So Mohammed has asked, wondering when will a patient with pathogenic desmin mutation require ICD therapy if normal function, but with PVCs? And Greg has answered that question. I don't know if there's any more to say about that.
Yeah, so Mohammed and I had a bit of a conversation. I think Mohammed is a physician. He's talking about a family he's looking after. So desmin mutations can cause a fairly aggressive form of arrhythmogenic cardiomyopathy, and traditionally we do use the level of LV dysfunction as a marker of risk. But I think all of us who work in this field appreciate that that is a very blunt tool. And particularly in the genetic cardiomyopathies, is not enough on its own to make a decision about things like ICD. So Mohammed and I had a discussion about looking at other features of the cardiac imaging, like levels of fibrosis, other ECG abnormalities, whether the patient has any symptoms, that sort of thing. But to echo what I'd said earlier, while you can try to work towards an objective risk, the decision about a defibrillator is partly to do with that, but also partly to do with the risk perception of the individual. And Mohammed had mentioned that in this particular family, there had been multiple sudden cardiac deaths in other family members.
Right.
And really that will lead to anxiety and concern, and that has to be taken into consideration about an ICD as well.
Lovely. Thank you, Greg. Another question here. What kind of therapy is possible for toddlers or young children with symptomatic Brugada? Asking about therapy.
I would say I'm not a pediatrician, so I would put that before anything. Any
right.
answers.
We need Jan Till here, don't we, from Royal Brompton? Yeah. Okay. Erica, maybe I'll ask Jan Till at the Royal Brompton Hospital, because she's a paediatric cardiologist. Someone else has got a question concerning the Brugada syndrome. In Germany, it's not possible to get quinidine anymore. So my husband has to take hydroquinidine now. We do not know yet if it's as effective as quinidine. Does anybody know if other medicine is available or have any information about that? Any other speakers?
I can tell
Thanks,
you.
Sylvia.
We are using hydroxyquinidine in our patients, and we have demonstrated that it is as effective as other type of quinidine. So I think that if you want, you can contact me and we can maybe go more in detail. I just don't want to say dosages or things like that, and in this forum now. But if you want, you can get my email and we can talk about the hydroquinidine.
Thank you, Sylvia. I've got another question here that somebody asked prior to the meeting. How often should adolescents be monitored for hypertrophic cardiomyopathy? I don't know whether Lima or maybe Devendra.
With a confirmed diagnosis, Anne?
Yes. No. Should they be? So, how often, if maybe a parent has hypertrophic cardiomyopathy, what about the children? How often should they be monitored?
So that's slightly different depending upon whether a misprint is known and they have the misprint, or whether it is just family screening based on clinical features that we are looking for. In our service, how we do it, Anne, is if the father has hypertrophic cardiomyopathy, we tend to start offering clinical screening for children from probably roughly around the age of 10. And depending upon their clinical features and what has been shown, we would then kind of adjust the interval of repeat screening for those individuals. If they are affected and they show early signs of hypertrophic cardiomyopathy, it would probably be on a yearly basis. If they are unaffected and don't have any features suggestive of hypertrophic cardiomyopathy, we'd probably do it every 2 years during the growing phase.
Right. Thank you, Lima. Yes. Another more practical question, somebody with an ICD asking about magnets and household equipment and what should they avoid? What sort of household equipment should they look out for? And also mobile phones and any effect on their ICD. I don't know.
I'll probably comment on that. So ICDs can be affected by electromagnetic fields. So it's anything that generates a strong current has the potential to interfere with ICD function. And generally what happens with defibrillators is if they're in a strong magnetic field, that could disable the defibrillation function of the ICD. Having said that, the absolute risk of any household equipment is extremely low. Commonly experienced things are induction hobs. So induction cookers, we recommend patients to be 50 to 60 centimeters, which is about an arm's length away from that. Mobile phones not to be carried in a pocket over the device. The manufacturers of the devices do produce very detailed lists of potential interactions with a variety of household equipment. So patients can ask their physiology department to provide them with that. But in general terms, with a few minor precautions, there's nothing too concerning within the household.
Yes, yes. And I think Medtronic, whether it's their device or not, will give quite a, on their websites as well, I think they give quite a lot of information about the implantable devices. Sorry? And also if people are travelling, they will also give them information. Are there any more questions there? There's no more questions. I wonder, Devendra, would you be able to maybe tell people a little bit about the genomic project that you're heading?
Thank you, Anne. Yeah, it's been from the speaker so far. I mean, I've really enjoyed talk, especially Professor Silvia Priori talk on the range of biological therapies and the scope, and more clinical presentation from Greg and Lima. I think each time I think we come across more and more information, especially the genotype-phenotype correlation and how those could be used in clinical decision making. So the field is fast expanding. The project which I'm involved is really trying to develop international cardiovascular genomic database between here in the UK and also South Asia. And we are interested on the kind of the genotype we have a lot of variants, unknown significance, a lot of founder variants in South Asian heterogeneous populations across India and including Sri Lanka. And there's also some link with the South Africa as well, but that is in pipeline. I'm hoping that at the William Harvey Research Center, the cardiovascular genomics unit, we're trying to build up a project so that the main validation and also the bioinformatic analysis, the database information annotation could be also added to that. I think the problem is, as you can imagine, that we have got most information is mostly from European and Caucasian people with very small numbers from the UK Biobank added to that. And invariably, we have people are finding many variants in South Asia, India, and which is very difficult to interpret because there is no reference population database at all. I think that is a project we are trying to build up.
Right, yeah, that's absolutely brilliant. All these databases bringing so much to get information together, aren't they?
I mean, as you know, there's a big move in the genomic world itself, and there's a big project called Pangenome, which is looking at ancestral variants in different population groups, and the focus not only in the Mendelian condition, but also in the complex condition as well. I think there is a big field out there, which will be the kind of future. I think because technology is now available, getting more and more cheaper, more people can have access to genome sequencing. I think that's a very small part of the whole process. We used to be a very big part a few years ago because it was very expensive, very attractive. And now I think we realize that genome sequencing data coming out from the lab is just a very small part. The bigger part is what actually happens in the clinic, what actually happens to the family, what happens in large population level.
Yes, and it was good to hear people, speaking about the well-being of the patient, and the mental impact of being diagnosed, as Greg mentioned, with a condition.
Another big issue of what I have come across, I think, from my experience working in South Asia and also other countries, is a huge ethical issues. I mean, people are making decisions. We mentioned about ICD children, they're very expensive, and there are no proper decision-making process. Lifelong screening, very random and varies from hospital to hospital. And then there are no protocol. So there's a huge amount of work to be done. That's where I think the project which we are running from here is called UK-India Genomic Medicine Alliance. So in which many mainstream, the emphasis on mainstream medicine involvement, cardiology is very important, cardiovascular. And then others are oncology and rare diseases. So I think the scope is very broad, but cardiovascular, because as you know, that it is the biggest killer, including the burden of diabetes added to that. So I think this is the project which we are trying to build up.
Yeah, it's an enormous project, but it'll be very, very worthwhile. Thanks for that, Devendra. Are there any more questions? Well, we're breaking into groups at 12:30. So I don't know if one might take a comfort break there, maybe mute yourselves and take the video off and come back at 12:30. And then everybody will be put into the breakout rooms. The speakers are welcome to join us if they wish, but I'd like to thank them anyway for helping us today and giving up their time freely today. It's really, really been very helpful. So thanks for that. So as I say, if we come back at 12:30, and then I believe we'll be assigned to the various breakout rooms where we'll be in smaller groups, and that will be for England, Spain and Germany. So I hope to see some of you a bit later.